Welcome to General Surgery Education channel. In this presentation, I will deal with acute acalculous cholecystitis. These are my objectives. Acute acalculous cholecystitis is a rare but potentially lethal disease defined as acute transmural inflammation of the gallbladder in the absence of identifiable gallstones. Duncan first recognized it in 1844 when a fatal case of acalculous cholecystitis complicating an incarcerated hernia was reported. This slide provides us with some information regarding the epidemiology. As you know, we have two types of acute cholecystitis: acute calculous cholecystitis and acute acalculous cholecystitis. Calculous cholecystitis is more common, and acute acalculous cholecystitis is the less common type and accounts for less than 15% of all cases of acute cholecystitis. Most common the case will happen in critically ill patients, and it occurs in about 0.2 to 0.4 of all critically ill patients. The condition can occur at any age, although a higher frequency is reported in persons in their sixth decade of life. Acalculous cholecystitis has a slight male predominance, unlike calculous cholecystitis, which has a female predominance. There are several complications of acute acalculous cholecystitis, which are empyema, perforation, gangrene. Most studies show about 40% occurrence. It is associated with high mortality rate, ranging from 10 to 90%, and this is depending on the time of diagnosis. So if you diagnose it early, the mortality rate will be as low as 10%, but if you diagnose it late, the mortality rate will be as high as 90%. But most studies shows the mortality rate in about 30%. Regarding the risk factors, we can divide them into commonly associated risk factors and rarely associated risk factors. Actually, they are in descending order. So let's start with the commonly associated risk factors. The most common risk factor is the trauma, especially if the patient is admitted to the hospital and clinically developed tachycardia more than 120 beats per minute, his or her injury severity score of 12, and transfused with more than 12 units of blood. Recent surgery, intra-abdominal surgery or extra-abdominal surgery including cardiothoracic surgeries, shock of any kind, burns, sepsis and infection, bacterial, fungal, bacterial, viral, critically ill patient, any patient requiring ICU care, TPN use, typically more than 3 months, prolonged fasting. Rarely associated risk factors are hypovolemia, post-ERCP, increased length of hospital stay, immunodeficiency, chronic illness, vasculitis, and obstruction. For the pathophysiology, we have two important theories which are implicated: biliarostasis and gallbladder ischemia. Here we have a study which provided excellent histologic data that explains some of the pathology of acute acalculous cholecystitis. They were studying 34 gallbladders with acute acalculous cholecystitis and compared them with 28 cases of acute calculous cholecystitis and 14 normal gallbladders, and they found the following: acute acalculous cholecystitis is largely a manifestation of systemic critical illness, whereas acute calculous cholecystitis is a local disease of the gallbladder. And the study showing the following histopathologic features of the acute acalculous cholecystitis: increased leukocyte margination, and this is corresponding to ischemia and reperfusion injury; increased focal lymphatic dilatation with interstitial edema associated with local microvascular occlusion, and this is ischemic related; and increased and deeper bile infiltration in the gallbladder wall, suggesting that bile stasis and increased epithelial permeability exist, leading to epithelial damage. These findings support the hypothesis that polystasis and ischemia are involved in the pathogenesis of acute acalculous cholecystitis. However, this model does not explain the development of acute acalculous cholecystitis in the outpatient setting or when acute acalculous cholecystitis occurs without any known risk. So it is evident that despite many attempts and many theories to explain the pathogenesis of acute acalculous cholecystitis, it is still not completely defined. Clinical features depend on the condition of the patient. If the patient is alert, there will be similar to acute calculous cholecystitis, which are right upper quadrant pain and tenderness, fever, and leukocytosis. But most of the patients are unconscious, in which the clinical features are often masked. They might have fever, elevated white blood cell count, and elevation in alkaline phosphatase and bilirubin. These are indications for further investigations. So the diagnosis of acute acalculous cholecystitis, depending on the clinical features only, is very difficult because the clinical findings will not establish the diagnosis. There are many confounding factors. Patients usually are critically ill and might have no ability to corroborate findings while sedated, intubated, or unconscious in an intensive care unit. Other confounding problems may be the clinical features which are not specific. So the clinical features only give us a suspicion that this patient might have acute acalculous cholecystitis. So we need further investigations by using imaging modalities. There is controversy as to which imaging modality is best and which to use first in diagnosing acute acalculous cholecystitis. Generally, both retrospective and prospective studies have been quite small, limiting the critical evaluation of radiologic diagnosis. This is likely because acute acalculous cholecystitis is a relatively rare entity. Nevertheless, radiology criteria for the diagnosis of acute acalculous cholecystitis have been developed for the use of ultrasound, CT scan, and HIDA scan. MRI generally is not used because it is a long procedure and it has no benefit over the other modalities. CT scan offers little benefit over ultrasound unless there is concern for other intra-abdominal processes that would not be seen by ultrasound. Therefore, ultrasound and HIDA scan have come to the forefront for diagnosis of acute acalculous cholecystitis. Now, considerations in the critically ill patients are the difficulties in transportation to and from radiologic suites. So many studies have focused on bedside modalities, ultrasound. Let's talk more about the ultrasound. Ultrasound is the modality of first choice to evaluate suspected acute acalculous cholecystitis because it is a rapid procedure. You can repeat it as many times as you want, and you can do it on bedside without transporting the patient to the radiologic department. In this slide, we have the ultrasound diagnostic criteria. We have major diagnostic criteria and minor diagnostic criteria. To diagnose patients with acute acalculous cholecystitis, we have to have two major or one major and two minor. Major criteria are the following: 3.5 to 4 millimeter or more thick wall, pericocystic fluid, intramural gas, sloughed mucosal membrane. Minor criteria: echogenic bile, sludge, and hydrops. What is hydrops? Hydrops is distension greater than 8 cm longitudinally or 5 cm transversely with clear fluid. There is an important point regarding the ultrasound diagnostic criteria. Some of these criteria may be present in some ICU patients who never manifest acute acalculous cholecystitis. So we have to have an approach to use ultrasound. We have to have a high initial index of suspicion, know the associated risk factors for acute acalculous cholecystitis, appreciate that some ICU patients can have abnormal gallbladder findings without acute acalculous cholecystitis, and if the patient has abnormal findings, then we need to do daily ultrasound. Here we have a longitudinal and horizontal ultrasound of a 64-year-old man with positive Morpheus sign, showing the hydrops. The gallbladder is distended with clear fluid inside. Regarding the CT scan, it offers little benefit over the ultrasound, requires the transportation of the patient, and the criteria are the same for ultrasound. Here we have a nice CT scan showing thickened gallbladder wall, hydros of the gallbladder, and pericholecystic inflammation. HIDA scan is a procedure that lasts from 1 to 6 hours, sometimes up to 24 hours. It involves the transportation of the patient to the nuclear medicine suite. Several modalities of HIDA scan have been studied for acute acalculous cholecystitis, which are radionuclide cholecystoscopy (RC), morphine cholecystoscopy (MC), and cholecystokinin augmented HIDA scan. Briefly about the procedure, the radiolabel technetium is injected, and if at 1 hour the gallbladder is not visualized, the RC considered positive. In this case, some advocate the injection of intravenous morphine to augment the study as confirmatory measure because of high false positive rates. If the gallbladder is not visualized in 30 minutes after morphine injection, it is considered a positive study. If the RC and MC are positive or intermediate, standard cholecystokinin can be injected. If the gallbladder responds normally by contracting and emptying, acute acalculous cholecystitis is unlikely because the sick gallbladder should not respond. This slide shows us the false positive and false negative tests which occur for various reasons. False positives have been noted to occur from 5 to 90% for RC. False positive HIDA scans can occur from prolonged fasting more than 24 hours, especially associated with TPN use, severe hepatocellular disease, severe illness, severe chronic acalculous cholecystitis, analgesia, and of course prior cholecystectomy. False negative results occur rarely in about 1% of cases of RC or MC. False negative results may occur because of cystic duct patency despite a distended gallbladder, bowel loop stimulation of the gallbladder, bile leak from the gallbladder perforation, tracer activity in the kidneys stimulating the small bowel or gallbladder. Finally, let's talk about the treatment of the acute acalculous cholecystitis. We have two treatment options, either to drain the gallbladder by cholecystostomy or we do cholecystectomy. ARCP drainage is generally believed to be inferior therapy and seldom is performed. For percutaneous cholecystostomy, it can be transhepatic or transperitoneal, but most of the surgeons prefer to do transhepatic to avoid the risk of bile peritonitis. In percutaneous transhepatic cholecystostomy, a pectoral catheter is inserted under ultrasound or fluoroscopic guidance. After that, we collect samples for gram staining and cultures. Small amount of contrast agent is injected to confirm position of the catheter. Then the catheter is secured to the skin by using suture material. After that, we leave the catheter to drain by gravity. Regarding the cholecystectomy, it is generally the definitive therapy if it can be performed. There is a debate of its optimal time. Some propose to do cholecystostomy alone. Some will say cholecystostomy is only a bridge to safer cholecystectomy. And there is also a debate whether to use open or lap cholecystostomy. Laparoscopic surgery has been favored in recent years because it can be both diagnostic and therapeutic, is less invasive, and has a similar morbidity and mortality compared with open procedures. However, it is noted that it may have to be converted to open cholecystectomy because of the inflammatory state of the gallbladder. This slide actually summarizes the management of acute acalculous cholecystitis. Ideally, when acute acalculous cholecystitis is suspected, cholecystostomy should be performed immediately because the patient might improve with this alone. If improvement occurs with decompression of the gallbladder, the tube can be removed after 3 weeks, and can be the only treatment needed. If there is no improvement, the diagnosis should be reconsidered, and if positive, urgent cholecystectomy should be strongly entertained because it can be life-saving when this is the source of abdominal sepsis. This is the end of this presentation. Thank you for your listening.